Welcome to the Funnel Effect. Today we are strapping in for a really deep dive into, well, one of the most rapidly evolving areas in cardiology right now. It's complex, it's vital. We're talking about the state of the art in left atrial appendage occlusion, or LAAO, and our guide for this is truly comprehensive. It's a landmark state of the art review. The authors are a real who's who: Jalish Garg, Rajesh Kabra, Rakesh Gopinathanair, Luigi Di Bias, Didi Wang, Jacqueline Saw, Rebecca Hahn, James V. Freeman, Christopher Ellis, and Dhananjaya Lakiriti. Yeah, that list alone tells you this is the definitive map of the LAAO field as it stands today. I mean, think about it over just the last couple of decades. LAAO has gone from being this kind of niche idea to, well, a mainstream and incredibly important way to prevent strokes, specifically for patients with non-valvular atrial fibrillation, AAF. So these sources, they really give us a fantastic shortcut, a way to grasp the biggest leaps forward in the devices themselves, the strategies used in procedures, and maybe most importantly, the clinical evidence that backs this whole shift up. It's definitely a field buzzing with innovation, but also one packed with clinical complexities.
That's exactly right. And while the technology, the devices have made huge strides, this review really lays bare that, well, a lot of the foundational concepts, they're still actively being debated. And honestly, that's where the real learning curve is. So for you, our listener, our mission today is kind of twofold. First, we absolutely have to unpack the basics, the anatomy, the physiology, the why behind LAAO being so critical in the first place. And second, we really need to dig into the big unanswered questions, the ones that still challenge doctors every day. Things like, who's the perfect patient for this? Which device works best for which type of anatomy? And then there's the whole kind of messy reality of what drugs to use afterwards, the antithrombotic regimens. Plus, managing those crucial long-term issues like clots forming on the device itself, we call that device-related thrombus, or DRT, and leaks around the device, para-device leaks, PDLs. There's a lot to unpack there.
Okay, let's start right at the beginning then, the pathology. Because you can't really appreciate how complex the fix is without understanding the problem itself. Why exactly is the left atrial appendage, this, little pouch off the atrium, why is it such a danger zone when someone has atrial fibrillation?
It's dangerous primarily because it's basically ground zero for blood clots in AF patients. Our sources hammer home that statistic we often hear, but it's worth repeating. The LAA is where you would find the thrombus well over 90% of the time in non-valvular AF. It's just stats.
90%, wow.
Yeah, and even if you look at valvular AF, which is a bit different, it's still the source in 57% of cases. But, the danger isn't just about clots forming mechanically. The LA itself can actually trigger AF episodes. It's what we call a source of non-pulmonary vein trigger, so it's an electrical problem spot too.
Oh, okay, so it's not just a stagnant pool waiting for a clot, it can actually stir up the rhythm problem itself.
That's interesting. Before we get into the fixes, let's really get into the anatomy. Because calling it a finger-like structure, well, that really doesn't do justice to the challenge it poses when you're trying to plug it up, does it?
Not at all. It's structurally unique in every single person. Embryologically, it comes from the primordial atrium and its location. That's key to the risk. It's tucked in there, but it's really close to critical stuff. Superiorly, you've got the pulmonary artery right there.
Right.
Inferomedially, it bumps up against the left ventricular free wall. And critically, the left circumflex coronary artery often runs right next to the LAA opening, the ostium, on the inside wall.
So a slip-turning deployment.
Exactly. Any deep placement, any trauma during the procedure, you could easily injure the coronary artery. Or worse, the stakes are incredibly high. You're trying to prevent stroke, but you have to avoid causing an immediate disaster like tamponade or coronary damage.
That makes sense. So anatomically, how do we break it down? You mentioned the ostium. Yeah, we typically divide it into four parts. The ostium, which is the opening or entrance, the neck, usually a slight narrowing, the main body,
Yeah.
and then the tip. But that ostium, the entrance, it's particularly tricky. Why? Because it's incredibly variable.
How variable?
Well, in most people, maybe 69%, it's oval.
Yeah.
But you also see shapes described as foot-like, that's about 10%, triangular, maybe 8%, teardrop, another 8%, and sometimes about 6% is perfectly round. Trying to design a plug that fits all those shapes perfectly, that's a real challenge.
And the sources mention these anatomical pits around the ostium. That sounds like another complication. What are those exactly?
They're small, but yeah, they're treacherous. Think of them as these tiny, thin, inward-folding bits of tissue mixed in with areas where the heart muscle itself is extremely thin, right near the LAA opening. And because that tissue is so delicate, so thin, they create three big problems for the person implanting their device. First, getting the device positioned just right and achieving a complete seal. It's really tough. The device might sit awkwardly over a fold, which increases the risk of leaks or even clots forming later.
Right, an incomplete seal.
Second, the complex structure can literally trap the catheters or wires you're using to get the device in place. That can make the procedure longer and riskier. And third, because the tissue in those pits is so thin, there's a much higher risk of accidentally perforating, tearing the tissue during device manipulation. This is exactly why getting really good pictures before the procedure with high-resolution imaging is just paramount.
That makes total sense. Now, speaking of complexity, let's move inside to the body of the LALA. When you look at CT scans or TE images, it's definitely not a smooth sac, is it? Which explains why blood just sits there.
Far from smooth. The inside is, well, incredibly varied. Most LLAs, maybe around 80%, are multi-lobed. That means they have two or more distinct lobes sticking out, often in different directions, kind of like a crumpled glove.
Okay.
And then, lining the inside are these thick, muscular bands called pectinate ridges. They create these deep, cavernous dead spaces and isolated little pockets. This whole architecture just maximizes turbulence in the blood flow, promotes stagnation or stasis. And stasis, of course, is the key ingredient for clots when AF is messing up the normal pumping action.
This brings us to that famous classification system based on shape. This is one of those things you hear about, that the shape of your LLA can actually predict your stroke risk. Let's break down those 4 common types people talk about.
Yes, this morphological classification is really critical for stratifying risk. Sometimes it's even more predictive than the standard CHA-2DS-DUVAS score. So researchers generally classify LAAs into 4 main shapes. First, there's the chicken wing. This is the most common, maybe 48% of people have this. It's characterized by a sharp bend, usually near the start or middle of the appendage. Because of that bend, the opening often points away from the main flow in the left atrium. This causes some turbulence, sure, but the overall risk is generally considered moderate.
Okay, chicken wing, moderate risk. What's next?
Next is the windsock. About 30% of people have this. It's typically a single large dominant lobe, often pretty deep and wide. Now, while the volume can be large, the flow pattern inside tends to be a bit smoother than the other complex types. So the thrombus risk here is also considered moderate.
Got it. Moderate again.
Then we have the cactus morphology. This is less common, maybe 12%. Think of a main central body with smaller lobes sticking out upwards and downwards, kind of like the arms of a cactus. Yeah. These complex, multi-directional lobes create lots of little pockets for blood to stagnate. So this one ranks as the second highest risk.
Okay, cactus is higher risk. And the last one is the broccoli.
That's right, broccoli, or sometimes called cauliflower. It's the least common, only about 10% of people, but it's the most dangerous.
Broccoli.
Yeah.
That seems odd. It doesn't sound particularly big or menacing. Why is the broccoli shape linked to the highest risk for clots and stroke?
Yeah, it is a bit counterintuitive. It's down to a specific combination of features. Typically, a broccoli LAA has a relatively smaller opening compared to how deep it is. And critically, it has a highly increased number of fine, tightly packed internal ridges or trabeculations.
Ah, so it's super complex inside.
Exactly. That incredibly complex, tightly packed structure creates the maximum potential for blood to just get stuck in little pockets and stagnate locally.
Yeah.
It becomes this perfect environment for clotting, even if the overall flow in the left atrium isn't severely impaired. So, yeah, if you have a broccoli-shaped LAA, your inherent stroke risk is significantly higher. And it's not just shape. Other factors matter too. Things like a larger overall LAA size, more volume, greater depth, a smaller opening diameter, and where the LAA takes off from the atrium, these also increase risk. It really highlights we're dealing with complex fluid dynamics here.
So the LAA is clearly a mechanical hazard, a thrombogenic pit. But its function isn't just about clots, is it? There's a physiological role, and blocking it off must have an impact.
Absolutely. Mechanically, the LAA is much more compliant and stretchy than the main left atrium, maybe 2 to 2.5 times more compliant.
Okay.
This high compliance means it acts like a really important decompression chamber. When the main LAA faces a sudden increase in pressure or volume, the LAA can quickly expand to absorb that spike, buffering the pressure and protecting the lungs. Early studies, especially ones involving surgically cutting out the LAA in animals, suggested that removing it actually impaired the LAA's ability to handle pressure changes and made it stiffer.
But wait, the review you mentioned suggests that percutaneous LAAO, plugging it from the inside, might actually help LA function. That sounds like a contradiction to those older surgical studies.
It is a critical distinction and a really interesting finding. Observational studies in humans after they've had a percutaneous LAAO device implanted, they've actually shown measurable improvements in LA function. Specifically, in its reservoir function, how well it fills up. its conduit function, how well blood flows passively through it, and its booster function, the kick from its contraction.
So plugging it helps the rest of the atrium work better.
The thinking is that while surgically removing the entire structure might be bad, just plugging a dysfunctional, stiff, poorly contracting appendage might actually improve the overall mechanics of the remaining healthy left atrium. You're essentially removing a mechanical hindrance.
Fascinating. And then there's the neuroendocrine aspect. You're saying it's not just a pump or a buffer. It's actually like a gland, too.
Precisely. The LAA plays a major role in neurohormonal modulation, basically regulating hormones involved in blood pressure and fluid balance. It is the primary site in the entire heart for producing atrial natriuretic peptide, or ANP.
ANP.
Yeah, it stores about 30% of the heart's total ANP in tiny granules. ANP is a powerful hormone. It relaxes blood vessels, helps the kidneys get rid of salt and water. It gets released when stretch receptors in the LAA wall are stimulated, say by distension, high pressure, volume overload, or even lack of oxygen.
So blocking the LAA affects this hormone system.
It seems to. Occluding the LAA base impacts this neurohormonal axis. Studies suggest that LAA closure might help downregulate other systems like the renin-angiotensin-aldosterone system and reduce adrenergic or adrenaline-like input. This could potentially lead to favorable long-term neurohormonal effects, although we're still learning about the full implications.
Okay, let's try to pull this all together into one picture for the listener. The pathogenesis. You mentioned AF worsens Virchow's triad. Can you quickly remind us what that involves?
Sure. Virchow's triad is the classic model describing the three main factors that contribute to clot formation. In an AF patient's LAA, you've got all three. One, stasis. That's the abnormal blood flow, caused by the poor contraction of the LAA itself during AF, the complex internal anatomy we just discussed, and the chaotic rhythm of AF. 2. Hypercoagulability. This is a state where the blood itself is more prone to clotting, often driven by chronic inflammation, activated platelets, things like that, which are common in AF patients. And 3, endothelial dysfunction. The inner lining of the LAA gets damaged or inflamed, making it sticky and promoting clot adhesion and growth.
So a perfect storm for clotting.
Exactly.
Yeah.
And on top of this mechanical and chemical storm, remember we said the LAA base and those pectinate ridges can be electrically active. They are often arrhythmogenic. They can act as sources of the arrhythmia itself due to stretch, fibrosis, or the presence of specialized pacing cells called DeBacher cells.
DeBacher cells.
Yeah, these cells can act as non-pulmonary vein triggers, essentially firing off extra beats and helping to perpetuate AF. So the LAA is really a constant source of trouble, mechanically, chemically, and electrically.
That's a fantastic summary. A convergence of all these issues really makes it clear why it's become such a key target for stroke prevention.
Precisely.
Okay, with that crucial anatomical and physiological background set, let's shift gears. How do clinicians actually go about sealing off or excluding this problematic appendage? Let's start with the old school approach, open surgery.
Right. Surgical LAA exclusion. That's really where this whole story started. Way back in 1949, a surgeon named Madden described excising the LAA.
Yeah.
But the initial attempts, they had pretty high rates of complications, neurological problems, major bleeding. So for a long time, it wasn't widely adopted, except maybe as an add-on during other major heart surgeries.
And even when it became more common, say during a Mays procedure for AF ablation, the quality of that surgical closure wasn't always great, was it? Which led to this issue of residual risk we see in older studies.
Yes, exactly. Inconsistency was the real killer. Historically, surgeons used all sorts of techniques, simple sutures, basic staplers, sometimes full excision. The problem was these often resulted in incomplete closure. The data is pretty sobering. One study showed that while cutting the whole thing out worked best, other techniques left behind residual stumps or pouches that actually contained clots up to 41% of the time.
41%. So nearly half the time, the problem wasn't fully solved.
Right. And this issue of incomplete ligation is critical. The sources emphasize that leaving behind a residual LAA stump, say 10 millimeters or longer, that's consistently linked to an increased risk of stroke or embolism, regardless of the patient's other risk factors. If you leave a decent-sized pouch, you haven't fixed the underlying issue.
So the goal had to shift towards making sure the exclusion was precise and, more importantly, complete, even during open surgery. And that led to modern surgical devices, like the AtriClip.
Exactly. The AtriClip system really became the standard for modern surgical LAA closure. It's basically a self-closing clip made of titanium with hinges of nitinol, that memory metal. Surgeons can use it during standard open heart surgery or deploy it thoracoscopically, through small incisions.
And how does it work? It just clamps it shut.
It applies constant, firm compression right at the base of the LAA. This cuts off the blood supply, causing acute ischemic injury, basically. The tissue dies off. Then, over time, that tissue distal to the clip atrophies and gets resorbed by the body. It creates a really robust, permanent seal.
What makes the actor clip specifically better than just sewing it shut, like they used to do?
It has some key advantages that address the old problems. First, it's repositionable. Before the surgeon releases it finally, they can adjust it to make sure it's perfectly placed, closing off the entire base without leaving a stump.
That was hard to guarantee with sutures.
Okay, repositionable, that's big. Second, it's less likely to cause tissue tears and bleeding, which could happen with older staplers. And third, its design is precise, which helps reduce the risk to that nearby left circumflex coronary artery we talked about. The data backs this up too. The Occlusion trial showed successful closure, confirmed by imaging later, in 98.4% of patients. It delivers that precise, complete closure that was often lacking before.
We should probably also briefly mention the devices that didn't quite work out. That's part of the story, too. The source specifically calls out the Tiger Paw system.
Yes, Tiger Paw was a really important, albeit tough, learning moment for the field. It had to be withdrawn back in 2015 because there was a noted risk of it actually tearing the LAA tissue during deployment. And tragically, some of those tears led to patient deaths. It just underscores how incredibly delicate this tissue is, and the fine line operators walk between getting a good seal and causing a catastrophe. And there are newer surgical options, too. Medtronic has a device called Penditure. What's interesting there is its fabric-free design. The idea is to minimize the foreign body reaction, adhesions, and inflammation that can sometimes occur around implanted materials.
Okay, moving from purely surgical to something more hybrid. Let's
Yeah.
talk about the lariat system. This one's a bit of an outlier, right? It seals the LAA from the outside, like surgery, but it's delivered percutaneously without a big incision.
The lariat system is, well, it's a pretty remarkable piece of engineering. It's a hybrid approach, an epicardial suture delivered percutaneously. It requires dual access. You go into the LA from the inside via a standard transeptal puncture, but simultaneously you access the pericardial space, the sac around the heart, from the outside, usually by carefully puncturing near the right ventricle. Then it uses these special magnetic-tipped guide wires. They call them PhenoWIRZ. One goes in endocardially, one epicardially, and they're guided to meet up, essentially finding each other inside the LAA using magnets.
Wow, okay, so the wires create this magnetic bridge, linking the outside of the heart to the inside, right at the LAA.
Exactly. Once those wires are aligned, a suture delivery system is advanced over the epicardial wire. This deploys a pre-tied suture loop around the base of the LAA on the outside. Then you just cinch that loop down tightly, legating the base.
And the principle here is?
It's twofold. Mechanical closure, obviously, but also electrical isolation. Tying off the base cuts off blood flow, causing ischemic necrosis, and the tissue beyond the suture eventually shrinks and gets resorbed, but it also electrically isolates the appendage from the rest of the atrium.
That dual benefit closure and isolation sounds great, especially for rhythm control, but what's holding lariat back from being used more widely? What are the main limitations?
Well, the biggest hurdles are probably regulatory and technical. It has FDA 510(k) clearance, but that's for soft tissue apposition, not specifically for stroke prevention. That impacts reimbursement and how readily doctors adopt it. Clinically, it requires getting that dry epicardial access, which isn't trivial. And there's an inherent risk of puncturing the right ventricle, which can lead to bleeding into the pericardial sac or even cardiac perforation. That risk, while manageable, is generally considered higher than with purely endocardial devices. Plus, the anatomy has to be just right. Patients with really wide LAAs over 40 millimeters, or ones that point sharply upwards, or have very complex multiple lobes, they're often not suitable because you can't get the suture loop to cinch down uniformly around the base.
So despite those challenges, how well does it work when they can do it successfully? What's the data show?
When it works, the results look good. Observational studies from multiple centers report high rates of successfully ligating it acutely, maybe around 96%. And follow-up imaging shows complete closure in about 98% of cases. However, that risk of acute complications, especially cardiac perforation needing urgent surgery, was reported at 1.44% in one large study. While that number has likely come down with experience, it's still a bit higher than what we see with the current endocardial devices, highlighting the procedure's complexity.
Okay, that leads us perfectly to the most common approach today. The endocardial LAA occlusion devices. These are the plugs or seals put in from inside the heart after making that small hole between the atria, the transeptal puncture, or TSP.
Correct. And the current market for these endocardial devices is really dominated by two main design philosophies. These philosophies influence how the procedure is done and which anatomies they fit best. The first type is the single closure lobe design. The prime example here is the Watchman family of devices. That includes the older Watchman 2.5, the widely used Watchman FLX, which has a more rounded, less traumatic design and is easier to recapture if needed, and the very latest, the recently FDA-approved Watchman FLX Pro.
And what's the big deal about the new FLX Pro? What makes it different?
The FLX Pro represents a potentially significant step forward. It features a special fluoropolymer coating that's actually drug-eluting, similar to some coronary stents. The goal here is twofold. Maximize rapid endothelialization, getting the body's own lining cells to grow over the device quickly, sealing it off and making it biologically inert. And by doing that, minimize the risk of that dreaded complication, device-related thrombus or DRT.
Okay, makes sense. Faster healing, less clotting. And the second main design type, you mentioned the amulet family.
Right, that's the dual mechanism closure design. These devices use two components, an inner lobe that anchors down inside the LAA, and then a larger, flatter disc that sits proximally and covers the opening, the ostium. This category includes the older Amplatzer cardiac plug, or ACP, and the current generation device, the amulet.
And the advantage of that two-part design.
It offers a different way to handle various LAA shapes. The dual closure, with the disc covering the opening, can be particularly useful for LAAs that have very wide or shallow ostiums, where getting a single lobe device like the Watchman to anchor securely and provide a complete seal might be more challenging. They just offer different mechanical solutions to the same problem.
Right, different tools for different jobs, essentially.
Precisely.
Okay, this brings us right into the practical side. Who actually gets these devices, and how do doctors plan for the procedure? This seems critical given the complexity.
Absolutely critical. So if you're a clinician, you know the standard guidelines. They recommend oral anticoagulation, OAC blood thinners like warfarin or the newer DOACs for patients with AF who have a CHA2DS2 VASC score of 2 or more if they're men, or 3 or more if they're women, indicating a significant stroke risk. So the textbook LAAO candidate, that's the patient who meets that stroke risk threshold, but has a real persistent non-reversible reason why they cannot take long-term blood thinners. Or maybe they have a very high HAS-BLED score, usually 3 or more, which means their risk of major bleeding on OAC is just too high.
That's the ideal patient profile. But you mentioned the real-world data from the big NCDR LAO registry shows a more complex picture.
Yeah, the reality is definitely more complex, and it highlights a gap. Patients getting LAO in the real world, according to the NCDR data, tend to be older. They have higher average stroke risk scores, CHA2DS2 VASC, and higher bleeding risk scores, HAS-BLED, than the patients who were enrolled in the original big clinical trials that got these devices approved. We also see more women getting the procedure compared to those initial trials. But here's the really striking data point, the one that often gets overlooked. In that registry, 8.4% of procedures were actually aborted after the doctors had already gained central venous access, meaning they'd started the procedure. And another 2.3% were canceled even before venous access.
Wow, hold on. We're talking about more than 10% of patients scheduled for LAO having the procedure canceled, sometimes after they're already prepped and on the table. That sounds like a huge issue with patient selection or pre-planning. Why were they being aborted?
It really underscores the difficulty. These patients whose procedures were aborted, they were consistently sicker overall. They unfortunately had higher rates of adverse events afterwards, even without the device. The reasons for cancellation were varied. Sometimes it was poor vascular access. Sometimes they found a dense clot in the LAA on imaging right before deployment that wasn't seen earlier. Or maybe the anatomy was just too challenging to allow for safe transseptal access or a stable device deployment. It really forces us to consider the whole patient, their frailty, their other illnesses, their long-term survival prospects much more carefully during that shared decision-making process. LAO isn't necessarily a low-risk procedure for the very oldest and sickest patients.
Okay, let's zoom in on that preparation stage then, which seems absolutely vital to avoid those last-minute aborts. Imaging is obviously key. We've got T, transesophageal echo, and CTA-CT angiography. How do they compare in the planning phase?
Pre-procedure imaging is non-negotiable. Its job is pretty standard across the board. First, rule out any existing clot in the LAA or any fluid around the heart, pericardial effusion. Second, define that LAA anatomy in detail: size, shape, orientation, number of lobes. Third, check out the surrounding structures, the mitral valve, that circumflex artery again. And finally, figure out the best spot to make that transeptal puncture, the TSP, to get the device in smoothly.
And you mentioned CTA seems to have an edge over T for planning. What gives CT the advantage there?
Yeah, CTA, especially with modern scanners, offers a definite technological edge for planning. It gives you a much larger field of view than TE and allows for sophisticated 3D reconstruction. But the real key, it lets the operator simulate looking at the heart from almost any angle, just like they will under live X-ray fluoroscopy during the procedure.
Ah, so you can basically rehearse the angles beforehand.
Exactly. You can pre-plan the specific fluoro angles you'll need. You can pinpoint the ideal spot for that TSP to ensure the delivery sheath goes straight into the LA opening, what we call coaxial alignment. Getting that alignment right is crucial for minimizing the risk of leaks, PDLs later on. CTA gives you a detailed blueprint. T gives you more of a real-time snapshot. It also helps spot weird vessel anatomy or pericardial problems that might affect epicardial approaches like lariat. You really need a good quality scan. Minimum 128 slice scanner is recommended.
But once the procedure actually starts in the cath lab, T is still king for guiding things in real time, right?
T absolutely remains the gold standard for intraoperative guidance and monitoring, especially for checking the seal right after deployment. But there's a growing trend, a push towards using intracardiac echocardiography, or IC, instead.
I see. That's the idea of doing the whole procedure with just one operator, the implanter, using an echo probe inside the heart and potentially avoiding general anesthesia. What's driving that, and what are the downsides?
The main drivers are efficiency, potential cost savings, and avoiding general anesthesia, which can be risky for some very frail patients. These new 4D ICE catheters, like the NuVision or Verisight Pro, they offer really advanced imaging, pretty close to what T can do with 3D and multiplanar views. However, doing an LAAO, guided only by IC, it's technically more demanding. There's definitely a steep learning curve for the operator. The catheters themselves are expensive. And right now, it's mostly being done in high-volume specialized centers. It's definitely an emerging technique with promise, but T is still more universally accessible and probably more robust for the majority of operators currently.
Okay, imaging sorted. Now, you need to get from the right side of a heart to the left, across the septum. You emphasize that transeptal puncture TSP location is critical for getting that coaxial access. Why is aiming low and posterior, inferior-posterior, usually the preferred spot?
Right, the TSP is typically done via the right femoral vein in the leg. Now remember, most LAAs point forward, anteriorly towards the chest wall. So to get your delivery sheath lined up straight with that forward-pointing opening, you need to come from slightly below and behind it. An inferior-posterior TSP, low on the septum and towards the back, provides the best angle, the optimal trajectory, to enter that anteriorly pointing LAA coaxially. If you puncture too high or too far forward, the sheath will likely hit the LAA wall at an angle. That increases the risk of perforation, and it almost guarantees the device won't sit centrally, leading to eccentric deployment and inevitably leaks.
So you have to tailor it.
Always. If you happen to have an LAA that points upwards, superiorly, then you'd actually need to puncture lower down, more inferiorly, to aim the sheath upwards. Coaxial alignment is everything. It ensures the device seals properly, minimizes trauma, and reduces leaks.
Okay, now for the big moment, deploying the device. These aren't just dropped in. There are strict checklists before the operator lets go of the delivery cable. Let's break down the criteria for the Watchman FLX first, the PASSES criteria. What does each letter really mean for the operator at that critical moment?
Yeah, the PASSES criteria are absolutely fundamental for the Watchman family. If the device fails on any of these 4 checks, the operator must pull it back, recapture it, and either reposition it or potentially switch to a different size. It's non-negotiable. P is for position. This means you need to confirm that at least 2/3 of the device's bulk is sitting inside the LAA cavity. Its shoulders should be nestled right at the ostium, the opening. If it's sitting too shallow, sticking out too much, it could embolize, pop out later, or definitely leak. Too deep, that's also bad. It can create turbulent flow behind it and risks forming that neo-appendage we'll talk about later.
Okay, position, 2/3 in. Next.
A is for anchor. This is the stability check, the tug test. The operator gives a gentle pullback on the delivery cable. Does the device stay firmly put? If it shifts significantly or looks like it might dislodge, it's not properly anchored. A good anchor means it can withstand the heart's natural contractions.
Right, gotta make sure it's stuck. Then S.
S is for size. This is arguably the most critical and often the trickiest part. You need to confirm the device is appropriately compressed by the LAA tissue. That the target is usually 10% to 30% compression compared to its nominal size. Too little compression, if you pick a device that's too small, means it's loose, unstable, high risk for embolization. Too much compression, if you pick one that's too big, means the device is squashed, rigid, putting excessive force on that delicate LEA wall. That increases the risk of perforation and those delayed pericardial effusions.
Finding that Goldilocks size. And the last S.
The final S is for seal. This is the leak check, done immediately with T. Keller Doppler. You're looking to ensure there's no significant flow getting around the device. The definition used in the pivotal trials was a leak jet less than 5 millimeters wide. But as we'll discuss, even that acceptable leak size is now being seriously questioned.
That level of detail really shows the precision needed.
Okay, and the criteria for the amulet device, the dual mechanism one, they have their own acronym, CLOAs. How does that differ, considering it has the lobe and the disc?
Right. The amulet uses the CLO criteria, which are specifically tailored to managing that two-component system effectively and safely. C is for circumflex. This is a crucial safety check. You need to ensure the inner lobe part of the device is safely positioned inside the LAA, well away from that nearby circumflex coronary artery. The rule of thumb is usually a separation of at least half the device diameter. Given the amulet lobe can be a bit stiffer, avoiding coronary impingement is paramount.
Okay, keep it away from the artery. L.
F.
L is for lobe shape. When deployed correctly inside the appendage, the lobe should look tire-shaped on echo. This indicates it's achieved optimal compression against the LAA walls, similar to the Watchman sizing criteria. It confirms the lobe is anchoring securely without being over or under compressed.
Tire-shaped. Got it.
O is for orientation. The lobe needs to be sitting coaxially, aligned with the main axis of the LAA, not tilted or pushing laterally against one wall. Again, this minimizes stress on the tissue and helps with stability.
Makes sense. S.
S is for separation. This refers to the relationship between the inner lobe and the outer disc. They need to be properly separated but also correctly aligned. This ensures the lobe is doing its anchoring job deep inside, while the disc is positioned to cover the ostium effectively, without protruding too far back into the main left atrium.
Okay, proper spacing between the parts. And finally, E.
E is for elliptical. When the operator applies slight tension, pulling back on the system just before release, the outer disc should adopt a slightly concave, elliptical shape against the LAA ostium. This confirms it's snugged up tightly against the opening, creating a good seal.
Okay, close criteria for amulet. It's clear that deploying these devices is far from simple. Now, even with all this careful planning and these checks, acute complications can still happen. Let's talk about the most serious one first. Pericardial effusion or tamponade, PE.
Yes, PE is definitely the most feared immediate complication. It usually happens if the LAA wall gets perforated or torn during manipulation of the wires, sheath, or the device itself, leading to bleeding into the pericardial sac around the heart. The good news is the incidence has really dropped quite dramatically over the years. This is thanks to better operator experience, refinements in technique, using softer sheaths, and the introduction of more atraumatic device designs, like the Watchman FLX.
So what are the current numbers looking like for PE?
For the latest generation Watchman FLX, the rate was 1.0% in the Pinnacle FLX trial. And even better, it was down to just 0.51% in the huge Surpass registry, which looked at over 16,000 implants. So less than 1%, which is pretty good. However, it's important to note the comparative data from the Amulet IDE trial. That study showed a higher rate of PE with the Amulet device, 2.4% compared to the Watchman arm in that same trial, which was 1.2%.
A noticeable difference. Any idea why the amulet might have had a higher rate in that trial?
The likely explanation relates back to the device mechanics we just discussed. The amulet generally has a stiffer lobe, and there's potentially increased tension applied to the LA wall when the disc is released after the lobe is deployed. This might lead to a slightly higher risk of tissue trauma, especially if the device is oversized or not delivered perfectly coaxially. Most clinically significant PEs happen within the first 24 hours, and they need quick recognition and treatment, usually draining the fluid with a needle, pericardiocentesis.
Okay. What about the device actually breaking loose and floating away, device embolization? How often does that nightmare scenario happen?
Thankfully, embolization is rare, but potentially catastrophic if it happens. The overall incidence is very low. For the Watchman 2.5, the NCDR registry reported it at just 0.07%. However, again, that Amulet IDE trial showed a difference. The embolization rate was higher for the Amulet device at 0.7% compared to 0.2% for the Watchman in that head-to-head comparison. It's important to remember the vast majority of these events, when they do occur, happen within the first 5 minutes after deployment. That's why those immediate post-deployment checks with pass or close are so incredibly critical.
If it does embolize, what's the plan? Does it automatically mean emergency open heart surgery?
Not always, fortunately. In many cases, the device can be retrieved percutaneously using snares, bioptomes, or special forceps passed through larger sheaths, maybe 14 to 18 French. The goal is obviously to grab it and pull it out of the left atrium before it can travel downstream and cause a stroke or block a valve. However, if percutaneous retrieval fails, or if the device gets lodged somewhere really dangerous, like near the mitral or aortic valve, then yes, emergent surgical intervention becomes necessary. This really emphasizes why getting the sizing right, ensuring a good anchor, and avoiding excessively deep implantation are the best ways to prevent embolization in the first place. And finally, we should briefly touch on interprocedural stroke, a stroke happening during the LAO procedure itself. Right. These are exceedingly rare. Thankfully, rates are less than 0.5%. When they do occur, it's usually due to one of two things. Either air embolism, tiny air bubbles getting into the system, often from not meticulously flushing the large sheaths used, or de novo thrombus formation, meaning a fresh clot forming right there on the delivery system itself during the procedure.
This usually happens if the patient's blood isn't adequately thinned, specifically if the activated clotting time, the ACT, falls below the target range, which is typically 250 to 300 seconds. Maintaining that therapeutic ACT level throughout the procedure is absolutely non-negotiable for safety.
Okay, so we've navigated the procedure itself and the immediate risks. Now let's shift to the longer term, managing the patient after they go home. The sources flag two persistent hurdles that can really undermine the whole point of LAAO: paradevice leak, PDL, and device-related thrombus, DRT. These sound like the real Achilles heels of this approach.
They really are, because if you have significant leak or clot, you haven't fully addressed the stroke risk. Let's tackle the leak first, PDL. By definition, PDL is any active, unprotected blood flow communication between the main left atrium and the LAA past the implanted device. TE is still the most common way to detect leaks during follow-up. But CTA, CT angiography, is really emerging as superior here. Why? Because it can better characterize the leak's exact size and shape, and it often picks up leaks that T misses entirely. It can even identify things like intradevice leaks, suggesting the device surface itself hasn't fully healed over or endothelialized.
You mentioned earlier that the type of leak often depends on whether it was a surgical closure or an endocardial device. Can you remind us about the gunny sac effect versus the edge effect?
Sure. Understanding the mechanism helps understand why leaks happen. Leaks after surgical closure or the lariat procedure tend to be central. Imagine cinching a sac close the tissue bunches up in the middle, potentially leaving a small central channel. That's the gunny sac effect.
Yeah.
Leaks around endocardial devices like Watchman or Amulet, however, are usually eccentric. They occur at the edge effect between the outer perimeter of the device and the wall of the atrium. This typically happens due to imperfect sizing, the device not being perfectly centered, non-coaxial deployment, or just a really complex, irregular LAA opening that the device can't perfectly conform to.
So how common are these leaks? Even with the newer devices, the numbers seem surprisingly high still.
They do remain prevalent, which is a concern. For the latest generation Watchman FLX, studies report PDL rates around 10.5% at the 12-month follow-up mark. For the Amulet device, the rate cited in its pivotal IDE trial was higher, around 37% at 12 months. Although it's fair to add that in that same trial, the Amulet actually achieved a significantly higher rate of complete closure, meaning no leak at all, by 45 days compared to the Watchman. So the picture's a bit nuanced.
Okay, but this leads to the big clinical puzzle, the PDL paradox. You said the original benchmark for success was a leak less than 5 millimeters. That always sounded a bit arbitrary.
It was totally arbitrary. It was just an operational cutoff used in those early pivotal trials like Protect AF and Prevail to define procedural success. The PDL paradox emerged when researchers pooled the long-term follow-up data from those trials. What they found was really startling. Those acceptable leaks, the ones less than 5 millimeters, they were actually associated with a nearly twofold increased risk of ischemic stroke or systemic embolism over 5 years. The adjusted hazard ratio was 1.94.
Wow. So even small leaks significantly increase stroke risk long-term. Why would that be if the device is blocking, say, 99% of the appendage?
It's thought that even a small, high-velocity jet of blood leaking around the device edge can be problematic. It creates local flow turbulence right near the device. This turbulence might delay or prevent complete endothelialization, that healing process where the heart's lining grows over the device, sealing it off completely. If that healing is delayed, the exposed metal or polymer surface of the device remains thrombogenic, acting as a potential site for inflammation and clot formation. Plus, there's evidence that even very small leaks, maybe less than 3 millimeters, can sometimes progress and become larger over time. So the emerging consensus is that the real goal should be zero residual leak if possible.
So prevention is key. Getting the seal perfect the first time is the best strategy.
Absolutely. Achieving that perfect coaxial deployment and getting the sizing spot on are the most important preventative measures. Now, if a significant leak is found later, especially in a patient who absolutely cannot take blood thinners, sometimes operators will try to close the leak interventionally using small coils or plugs. But honestly, the long-term data on the effectiveness and safety of closing chronic leaks is still pretty limited.
Okay, let's shift to the other Achilles heel. Device-related thrombus, DRT. This seems like the ultimate irony, putting in a device to prevent clots and then having a clot form right on the device itself.
It is the ultimate irony and a major concern. DRT is defined as any thrombus, any clot that forms directly on the atrial-facing surface of the implanted LAAO device. Interestingly, the appearance of the clot seems to vary a bit by device type. DRT seen on ambulant devices tends to be more sessile, kind of flat and broad-based, like a sheet often growing on the surface of the outer disc. DRT on Watchman devices, particularly the older generations, was often described as being more mobile, sometimes pedunculated, meaning on a stalk, and frequently originating near the central screw hub or other irregular surface features.
Is the rate of DRT getting better with newer devices like the FLX?
Yes, thankfully the incidence seems to be decreasing. With the older Watchman 2.5, rates were around 3.7% in major trials. With the newer Watchman FLX, that number has come down to about 1.7% at 1 year in clinical trials. However, and this is a big however, some highly specialized centers using advanced imaging like cardiac CTA for follow-up have reported finding some form of DRT in approximately 18% of patients. This suggests we might be significantly under-detecting DRT if we only rely on T for follow-up. It highlights a potential diagnostic gap.
18% with advanced imaging, that's a lot higher. You mentioned a proposed DRT risk score earlier. What factors put someone at higher risk for developing DRT after LAOO?
Right. Researchers are trying to identify patients who are more susceptible. Factors that contribute to a higher DRT risk score, say a score of 2 or more, include things like known hypercoagulability states. These carry a heavy weighting. Having had a pericardial effusion around the time of the procedure. Having non-proximal AF, meaning persistent or permanent AF, not just occasional episodes. Kidney problems, renal insufficiency, and critically, deep implantation of the device.
Let's pause on deep implantation. What exactly does that mean, and why is implanting the device too deep such a big risk factor for DRT?
Deep implantation generally means the device is positioned more than 10 millimeters back from the ridge, between the pulmonary veins and the LAA opening for single-lobe devices like Watchman, or maybe more than 5 millimeters back for the disc and lobe devices like Amulet. When the device is placed too deeply, it doesn't just seal the opening. It effectively creates a new small pouch or remnant space behind the device but still connected to the atrium. We call this a neo-appendage.
Ah, like creating a mini appendage behind the plug.
Exactly. And this neo-appendage is bad news. It causes severe blood flow turbulence in that space, and it significantly delays or prevents proper endothelialization over the device face. The body's lining just struggles to grow across it smoothly when the flow is so chaotic. This creates the perfect localized storm for thrombus to form right there on the exposed device surface.
So how serious is DRT when it's detected? Is it an immediate red flag?
Absolutely. Finding DRT is a major red flag. Data from the initial Watchman trials clearly showed that the presence of DRT was strongly associated with a significantly increased risk of subsequent stroke or systemic embolic events. The relative risk was about 3.55. So DRT needs to be treated promptly and aggressively because of this substantial risk, even though putting the patient back on strong blood thinners increases their bleeding risk, which was likely the reason they got the device in the first place.
That's the core management dilemma, isn't it? These patients got LAO because they were high bleeding risk, so what do you do when DRT shows up?
It's a real challenge. The standard approach is immediate intensive anticoagulation, usually either with warfarin, targeting an INR of 2 to 3, or with one of the DOACs, typically continued for at least 8 to 12 weeks, followed by repeat imaging to see if the clot is resolved. But the dilemma is stark. You put the device in because OAC was deemed too risky, and now you have to put them back on it. Furthermore, there's a significant issue of anticoagulation resistance. In about 20–25% of cases, the DRT persists despite treatment. And even if it does resolve, the recurrence rate is high if you stop the OAC again, maybe 35–50%. It makes long-term management and follow-up imaging really tricky for these specific patients.
This whole issue flows directly into the next big topic, the constantly evolving antithrombotic regimen after LAO. That initial FDA-mandated regimen sounds almost archaic now.
It really is mostly historical at this point. When the first-generation Watchman was approved, the FDA label mandated a combination of warfarin plus aspirin for 45 days. Then, That was followed by dual antiplatelet therapy, DAPT, usually aspirin plus clopidogrel, for a full 6 months. In today's practice, that specific regimen is rarely followed, largely due to bleeding concerns. NCDR data showed only about 37% of patients were actually getting that regimen between 2016 and 2018.
So what's the current practice, especially with the newer devices like Watchman FLX?
The Watchman FLX approval came with updated labeling, allowing for a different option. A DOAC, like apixaban or rivaroxaban, plus aspirin for 45 days, followed by just aspirin long-term. That's become a very common approach. But perhaps the most influential evidence driving the shift away from using DJPT alone right after the procedure came from the ADA trial. This was a really important study comparing low-dose apixaban against DJPT for the first 3 months after LAO.
Right, let's spend a moment on ADALA, because the results were pretty dramatic, weren't they?
They were transformative, honestly. The trial was actually stopped early because the results were so skewed. Low-dose apixaban was found to be vastly superior to DOAT. It dramatically reduced the combined rate of major bleeding, strokes or embolisms, and DRT. The event rate plummeted from a shocking 21.7% in the group getting DRT down to just 4.6% in the group getting apixaban.
Wow, nearly a 5-fold difference in bad outcomes. Why was the DOAC so much better than DOP in this specific post-LAAO setting?
The data strongly suggests that for this particular patient population, typically older, higher risk for both clotting and bleeding DDAPT alone just might not provide enough protection against clot formation during that critical early healing phase, while simultaneously causing too much bleeding. DAPT primarily targets platelets, but it doesn't address the underlying hypercoagulable state often present in AF patients as effectively as a DOI does. That short, intensive course of a DOAA seems to effectively suppress clot formation, while the device surface endothelializes, leading to much lower rates of DRT and ultimately fewer overall complications. Now, despite this strong evidence from AD-DALA, it's worth noting that in some parts of Europe, using DD alone right after LAO is still quite common. This is partly historical, driven by the earlier widespread use of the Implanzer devices. However, even propensity-matched studies comparing real-world outcomes have shown that DDT generally leads to significantly higher DRT rates compared to using OAC post-procedure, maybe around 3.1% versus 1.4%. So the safety and effectiveness of relying solely on DOP right after LAO remain pretty uncertain globally.
And what about those patients at the absolute highest bleeding risk? The ones who doctors feel truly cannot tolerate any OAC or even DAPT. What's the practice there?
Yeah, for those really extreme cases, sometimes clinicians opt for just a single antiplatelet therapy, SAPT, usually aspirin alone, right from the start. Or in the most extreme cases, maybe even no antithrombotic therapy immediately after the procedure. Now, some observational registries looking at these highly selected patients have suggested that the safety outcomes might be comparable. But we have to be really cautious interpreting that data. It's heavily influenced by selection bias. We desperately need good randomized trial data to guide practice here. There's an ongoing trial called Aspirin Only O that's looking specifically at early aspirin discontinuation, which will be really important for managing these highest risk patients.
Okay, let's pull back again and look at the bigger picture outcomes. How does LAAO actually stack up against just staying on medical therapy? Let's start with the old standard, warfarin.
Right. Against warfarin, the long-term data is actually very clear and quite compelling. If you pool the 5-year follow-up data from those original big randomized Watchman trials, Protect AF and Prevail, LAO resulted in significant reductions in several really important outcomes compared to warfarin. Specifically, a significant reduction in disabling strokes, the hazard ratio was 0.45, so roughly halving the risk. A massive reduction in hemorrhagic strokes, those bleeding strokes often caused by warfarin itself, hazard ratio 0.20, an 80% reduction. And importantly, a significant reduction in death from any cause, all-cause mortality hazard ratio 0.73.
So getting off warfarin saves lives long-term, mainly by reducing fatal bleeds.
That seems to be the main driver, yes. By removing the need for warfarin, LAO effectively eliminates the single biggest cause of hemorrhagic stroke in this population, leading to substantial long-term survival benefits.
Okay, but warfarin is the old comparison. What about comparing LAO to the newer, safer blood thinners, the DOACs? That's where things get trickier, right? Because DOACs cause much less bleeding than warfarin.
Exactly, that's the tougher comparison. The key trial here is PROG-17. It's currently the only completed randomized trial that directly compared LAAO using both Watchman and Amulet devices against standard DOAC therapy in high-risk AF patients. The main finding was that LAAO was non-inferior to DOACs for the primary combined endpoint, which included things like stroke, major bleeding, cardiovascular death, and significant procedural complications. Non-inferior means it wasn't worse. But the really interesting part was looking at the components. While stroke rates were similar, the LAAO group had a statistically significant reduction in non-procedural, clinically relevant bleeding over the long term.
Ah, so the main benefit compared to DOACs seems to be reducing long-term bleeding risk rather than necessarily being better at preventing strokes.
That's what Pruggy 17 suggests, yes. LAAO offers a way to get comparable stroke protection to DOACs, but with potentially less bleeding burden over the patient's lifetime because you eventually stop the blood thinners. It frames LAO more as a long-term safety strategy, especially for those concerned about bleeding.
And we also have really strong data now for surgical LAO done at the time of other heart surgery thanks to that LAOS, the third trial. That felt like a landmark study.
LAOS third was absolutely monumental, a huge, multi-center, double-blind randomized trial. It showed convincingly that adding surgical LAO during the time of other cardiac surgery like bypass or valve surgery significantly reduced the rate of ischemic stroke or systemic embolism by 42% over about 3.8 years of follow-up.
42% reduction, that's massive.
It is, and what's even more striking is that this benefit was seen even though the vast majority, over 75% of patients in both groups of that trial, were already taking long-term oral anticoagulation after the surgery.
So closing the appendage offered protection on top of blood thinners.
That's the implication. It provides powerful evidence that mechanically closing the LAA offers a benefit that's additive to systemic anticoagulation. It really opens the door to thinking about LAO more broadly, perhaps even for patients who can tolerate DOACs, especially if they're having cardiac surgery anyway.
Okay, let's pivot slightly. What about the impact of LAAO on heart rhythm itself and overall heart function? We touched on the lariat ligation causing electrical isolation. Does that actually translate into better AF control?
In some cases, yes. Ligation with lariat does electrically silence the appendage, and studies have shown this can lead to favorable electrical remodeling in the rest of the atrium. Several observational studies have reported a reduction in overall AF burden after lariat, and for patients undergoing dedicated catheter ablation for AF, deliberately isolating the LAA electrically is sometimes part of the strategy. Some studies suggest that adding circumferential LAA isolation during the ablation procedure might lead to significantly lower rates of AF coming back at 1 year.
But mechanically, blocking off the LAA, doesn't that risk causing problems, especially in patients with heart failure? You mentioned its role as a decompression chamber.
That is the crucial balancing act, absolutely. While we said that chronic, successful percutaneous LAAO seems to improve LA function over time, reservoir and conduit function get better. The acute effect of suddenly occluding the LAA can be different, especially if it's a large, compliant appendage acting as a significant buffer. Suddenly blocking that off can lead to an acute rise in left atrial pressure, a sort of volume overload state for the atrium. This pressure increase could theoretically trigger more AF initially, or even precipitate clinical heart failure, particularly in patients who already have borderline heart failure or a stiff, non-compliant left atrium to begin with. Operators need to carefully screen for this risk beforehand.
Right, makes sense. Okay, before we look ahead to the future, one last practical point: cost. Is LAAO actually cost-effective? These devices and procedures aren't cheap upfront.
It's a really important question, but the answer seems to be yes, remarkably so, over the long term. The source material confirms multiple studies have shown LAAO to be cost-effective compared to lifelong OAC therapy. One analysis using U.S. Medicare data, for example, found that LAAO actually became the least expensive strategy for Medicare by year 10 compared to lifelong warfarin or lifelong DOAC use.
How does that work out?
It's driven primarily by avoiding the high downstream costs associated with managing major bleeding events, especially devastating hemorrhagic strokes, and also the cost of long-term care after disabling ischemic strokes. Preventing those high-cost events over many years eventually outweighs the initial procedural cost. This strong clinical and economic argument is a big reason why professional guidelines now give LAAO a Class 2A recommendation, meaning it's reasonable to consider for those high stroke risk patients who have contraindications to long-term OAC.
Okay, let's turn our gaze forward then.
Yeah.
What are the biggest gaps in knowledge or practice that still need tackling in the LAO field? Where is the research heading next?
There are definitely several critical gaps remaining. First, as we touched on, the risk scores we currently use CA2DS2 VAS for stroke, has B-lead for bleeding. They're pretty blunt instruments. They're considered suboptimal for really predicting risk accurately in certain subgroups. We need better tools that perhaps incorporate anatomical factors like LAA shape or LA size, maybe biological markers of inflammation, to truly pinpoint who will benefit most from LAO, and just as importantly, who's at the highest risk for complications like DRT.
And that big question still looms. How does LAAO really compare head-to-head with DOACE in a broader patient population?
Exactly. We need definitive equipoise to DOACE. There are several large, crucial randomized trials ongoing right now, names like Option, Champion AF, Catalyst. These are designed to firmly establish whether LAO is non-inferior or maybe even superior to DOS across a wider range of patients, looking closely at that balance between long-term stroke prevention and long-term bleeding reduction. Until we have those robust long-term results, choosing between LAAO and a DOAC for patients who could potentially take either remains a challenging clinical decision.
There's also that issue of who gets studied versus who gets treated in the real world, the frailty bias.
Yes, the frailty bias is a key limitation of current evidence. Most of the big RCTs enrolled patients who are typically in their 70s reasonably functional. But arguably, the greatest unmet need for LAO might be in those significantly frailer patients, the octogenarians and nonagenarians, who genuinely cannot tolerate any systemic anticoagulation due to extreme bleeding risk or falls. We need dedicated studies in that very high-risk, fragile population to understand the true risk-benefit balance and make sure we're using the technology optimally where it might matter most.
And that PDL paradox needs sorting out. We need agreement on what to do about small leaks.
Absolutely. The PDL consensus is still lacking. There's no clear agreement on how clinically significant small leaks really are, especially those less than 3 millimeters. Observational data hints they might increase stroke risk and can progress, but what's the threshold for intervention? Should we try to close them? Or just put the patient back on a DOAC indefinitely? It's a huge gray area needing clarification.
So looking ahead, what are the most exciting developments in terms of new devices designed to tackle these gaps, like DRT and PDL?
The future device development is clearly focused on mitigating these known issues. The Watchman FLX Pro, which we mentioned is now FDA approved, is a prime example. That drug-coated polymer surface is specifically designed to accelerate healing, promote faster and smoother endothelialization, and thereby reduce the risk of DRT. We're also seeing innovation aimed at combining LAA occlusion with electrical isolation in a single device. The eCLA device is one example being studied. It actually integrates electrodes capable of delivering pulsed field ablation energy right into the occluder itself. The idea is to provide both mechanical stroke protection and potentially contribute to rhythm control by electrically isolating the LAA, all in one procedure, tackling both the mechanical and electrical roles of the LAA simultaneously.
That combination of mechanical plugging and electrical silencing really acknowledges the LAA's dual threat. It sounds like the field, while mature in some ways, is still very much evolving.
It absolutely is. And the ultimate implication here is the need for ongoing collaboration between doctors, researchers, industry, and policymakers. We need well-designed trials that specifically target these remaining shortcomings. And we need broader recognition of the potential long-term clinical and economic benefits LAAO can offer. Ensuring it continues to evolve as a safe, effective, and accessible therapy for the millions at risk of stroke is paramount.
Well, this has been an incredibly thorough and insightful exploration of LAO. We've really covered the waterfront from the tricky anatomy, like that high-risk broccoli morphology, all the way through to managing complex long-term issues like DRT and the PDL paradox, plus the huge shifts in drug therapy after the ADAL trial.
And perhaps a final thought for you, the listener, tying back to where we started with physiology. Given everything we now know about the LAA's role, not just in clotting, but in secreting ANP, acting as that vital decompression chamber, how will the long-term changes in overall left atrial mechanics after LAAO truly play out? We see evidence for improved reservoir and conduit function, but also that risk of acute volume overload. How will these subtle long-term mechanical shifts ultimately impact the longevity and quality of life for patients whose left atrium has to adapt to functioning without its appendage? That's really the next frontier question, one that will require decades of careful follow-up to fully answer.
That's a really profound point to end on. The LAA is clearly so much more than just a passive little pouch. Fascinating field to watch. Thank you for watching A Funnel Effect.